Okay, hey everyone. I'm sorry about the lighting situation of yesterday. Today I have light. So now you actually get to know what I look like with all my, whatever that is. But welcome back. And I'm going to go ahead and put up my slides. And I really do ask you to use the chat. So we're going to start out. Let me get my slides up. And then I actually have a question for you all. I'm hoping you can see where we are. So let me go to slideshow and get this started. Believe it or not, I'm just have this little tiny, there it is again. Doggone, did that bad thing again. Hang on one second. I'm trying to grab my, here we go. Hang on, we're gonna put it back like it's supposed to be. That's not. Okay, so my slides are a little strange because that's not what I wanted, but that's what I got. So hang on. Sorry, you guys. So let me just, while I'm doing this, my need to show you the slides that I'm trying to pull up and get into position is just to ask if there were any questions from yesterday. So if people do have some questions from yesterday, I would really appreciate it if you would just put them in the chat. And so I apologize, this is messed up, but I just lost my design and I don't know how to get it back. So we'll just ignore that one. So I just need to know if you have any questions or thoughts from yesterday, any areas of confusion or need for clarification. Is there something that you were thinking, wow, I don't think I really got that from yesterday or had a question? So I'll just give a moment. And if you do, can you put it in the chat, and then we'll just use this first time for just some opportunity for clarification. And if there's nothing, we'll get started. We're all on the same page. Donna, do you see anything of need?
It looks like we might all be on the same page.
Okay. All right. So I'm hoping my slides, somehow I've lost some of my formatting. So here's what we're going to talk about today. And it's a lot. Again, we're going to talk about sort of who are the clinical professionals who are part of the identification of deafblindness. We're going to look at some standard screening aspects, and that's going to include like risk factors, who's really at risk for early onset deafblindness. We're going to talk about some common etiologies tied to deafblindness, and I'm hoping that you will join me in an activity where I'm going to have you look up some conditions. We're going to talk about the ABC indicators of early onset hearing differences and the ABC indicators of early onset blindness and visual impairment. So this may be something that you do in terms of screening. This may be something you don't do. But what I will say is when we talk about the screening, these are all things that anybody, anytime should be observant. And it's just helpful to know these risk factors. So we're going to start by just talking about who are some of the clinical professionals. So we know who the people are in school districts. We talked yesterday that you may be working with an audiologist, a school-based audiologist. You may be working with an interpreter, an intervener, a teacher of the deaf, a teacher of the students with blindness and visual impairment, a teacher who's literally trained in deaf blindness, which is rare, an orientation mobility specialist. So those are folks who are classically trained in some element of disability that involves either deafness or blindness or both. But now we're going to kind of look and say, who are the clinical professionals? And these are the folks that are really important because they're in the diagnostic chair. So while we may see things that we worry about and we wonder about, ultimately, it's really the medical or the clinical professionals who are going to diagnose and do more quantifications from a clinical perspective before they hand off the kid back to us for more of a functional interpretation. So these are two specific to deafness. So we have an ENT, otolaryngologist, and the bottom line is this may be a physician who does see our kids who are ultimately diagnosed as having deafness or hard of hearing. And they have specialization in terms of the ear, nose, throat, and neck. And they may or may not be involved, but they're good people just to know about. The person who really is going to quantify the deafness or the hard of hearing levels as an audiologist. And the degree has changed in my lifetime. It is now at a level of a doctor of audiology. So people who are going to be audiologists are actually licensed from a doctor perspective, not a medical. It's be kind of like the equivalent of an education PhD or EDD, but they have a lot to learn and a lot to study. And not everybody is trained to be a school-based audiologist. We see people in a community who do clinical practice for lots of folks, but a school audiologist is trained to do all the things that we expect an audiologist to do, but also to understand the law, eligibility, and equipment that's really going to support a kid within a school district. So it might be like an FM system in addition to hearing aids from an application perspective. So just good to know who those people are. So this is my worry, doggone it. Hang on one second. I'm going to get out of here because this is exactly what I was afraid of, is my slides are compromised because of my design. I don't know. I guess I'm just going to do this. See, the problem is I've lost. So I apologize, but I'm going to lose, like right here is this big thing that's supposed to have content in it, and the design is not showing up. So I'm just going to try this because I think it will give me a little more content. I apologize for the delay, but that's what we're going to do. So your slides will be a little better, but I'm going to lose some of my content because it just quite honestly went away. Now we're going to talk about the ophthalmologist. So it is really important that people understand who the eye care specialists are, because depending who the person is from a training perspective, you get certain things and you don't get certain things. So an ophthalmologist is a medical doctor. So that's a difference from what we're going to talk about next, which is the optometrist. So this is a medical doctor and has the capacity for surgical care in the prevention and mitigation of eye disease that we talked about yesterday, that sometimes kids will benefit from somebody actually doing a surgery. They certainly are capable of treating refractive error. We talked about that a little bit yesterday, that kids can be nearsighted or farsighted or have astigmatism. They are licensed through a state and they are an MD. And that MD is different from the OD that we'll see next with the optometrist. And the big difference is that capacity to do medicine from surgery. So now we have the optometrist, and this is a healthcare professional who specializes in kind of the function and disorders. They are also people who can do diagnostics. They do what eye doctors do, our ophthalmologists do, where they're going to be doing refraction. They dilate the eye, they can look inside the eye. So they have the same capacity to really evaluate whether or not a kid has an eye condition. They may not have, usually, and sometimes it depends on states, the same capacities for surgeries. So if something is a retinal disease, we're going to go to an ophthalmologist. If we're going to do laser treatment, et cetera. So bottom line is the ODs are very important, especially for glasses. And also sometimes you will hear them offer vision therapy for kids. But if you need glasses or contact lenses, these are the people that obviously we want to spend time with. So I have two clips. I'm hoping that in this change of my design, I didn't lose it, but this is not a clip that's specific for a family hearing about deafblindness, but just how it may go that when our families go into eye doctors, sometimes they're going because they know there's a problem that may have resulted from a vision or hearing screening. Sometimes they might have had a referral from a pediatrician, et cetera. But let's just first see if I can play this. Oh man, this is not good. There we go. Okay.
At that time, I needed to know the truth about my son, but I also needed compassion from the person that was giving me this most startling news of my life.
We had very little to say at the time because, we set physicians up in the social structure of our world today as gods, basically. And they do great work, and they're tremendous people and provide a lot of good things for a lot of people. But when you're told by God himself that you have no hope, then you have no
So
hope.
I show that clip ahead of time because we're going to be talking about vision screening and what we can do to help identify visual and hearing loss, deaf blindness, if it doesn't come to us. Meaning sometimes we're the people that send the kids to the doctor. Sometimes we're the people that we receive the kids from the doctor. But what I will say to you is no matter which role you're in, the sender or the receiver, oftentimes parents come back from eye appointments pretty overwhelmed, or audiology appointments. Think about anything that has a diagnosis. It can be pretty catastrophic. It can be pretty devastating. And there's a lot of fear that families have, which puts more of a responsibility on us to sense make. And I'll talk about this when we get into some of the screening practices. But that's just one viewpoint of a family.
At that time, I needed.
We're going to go to the next one. And this is a clip that was done years ago. Deborah Chen and some people put together some modules. So it's specific to blindness and visual impairment. But this is an eye doctor who I noted how it should be done. And what I will say to you is that in our work, if you are a TBI and you have an opportunity to really work with eye doctors, if you are a TOD and you really have an opportunity to work with audiologists, as you form those relationships, this kind of clip or this kind of content may actually be a really great discussion. When I lived in Alaska, there was at that time 2 pediatric ophthalmologists, and for a while there was just one. And when I first started going to the eye appointments with the families, he really wasn't happy I was there. He was like, who is this person? At first, I think he thought it was a family member, and then he kept seeing me with different kids. And finally, we really started to break through and have some discussions. And one of the things that we talked about is some of the content that's in this video. How do you offer news? So let's watch it, and then I'm going to ask for you in your chat just to say, what do you think this doctor really did well? What do you think would be helpful to share with other doctors? Are there key points that we could be really working to share with our clinical providers when they share news?
When I go in to give catastrophic news, I always sort of say to myself, now remember, Lori, or now remember, the patient is more afraid than you are. But it's a very fearful thing. If you go in the room, you're a physician, you're in the job because you care about people. You want them to like you. You want to do something right for them. And you know that you're going to tell them, for instance, in the case of childhood eye cancer, that number one, you're going to have to tell them that their child has cancer. And secondly, that you may have to remove an eye. And both of those things, that they hear those words, and it's just the end of the world for their perfect baby. And you enter the room, and your immediate instinct is to want to flee, and your second instinct is to kind of want to lie, not because you want to lie to them, but because you just don't want it to be so awful. But both of those are the wrong things to do. You have a quiet time with them. You make sure that you don't look rushed. You make sure that you aren't rushed. It's just how it's got to be. You close the door, you don't have spectators, and you sit down with them. And I generally like to sit within a reasonable proximity of them, and I make sure that there's some Kleenex around, believe it or not, little details like that. People need to feel free to express emotion. It's catastrophic to hear that your baby has cancer and that maybe an eye is going to be removed. So you sit down, you look them in the eye, you have all the time in the world, and you tell them, and you remember they're not going to hear much, and you let them grieve.
Okay. Hang on.
When I go in to give
the next one. So in the chat, what do you think that this doctor did really well? What would you think might be a discussion point with someone that you may work with now or in the future who's really in the diagnostic chair? What did you like? Anybody in the chat?
Taking all the time that's needed, having patience and mindfulness. And no spectators, the doctor's taking her time. Looking at them in the eye. I like how the doctor remembered they need freedom to express themselves and grieve.
Would you give her any advice? That was a quick clip, but is there something you didn't hear that you wish she would have done?
Another comment is understanding that the parents will need to repeat questions because they will not get it all the first time.
Yeah, yeah. Anything else that was either good news or you wish she would have done?
There's another comment. I'm not sure if it's answering the first or your follow-up question, but support group and rescheduling.
Yep, great. So really, what we didn't hear was sort of a referral. So here might be a next step for your family. There might be a support group. There's other families. So in this case, they were talking about retinoblastoma, which is an eye cancer. Does the doctor know that there's a group of families either specific to retinoblastoma or just children who have blindness or visual impairment referral? So that's another talking point. That's great. Anything else?
That the doctor acknowledged her own fear, knew that needed to be frank but caring and allow for and expect the emotional response. Another comment, the doctor needs to remember that there are professionals who help kids to function without eyes and ears.
Yep.
Another comment, I think it would be important to give advice on parent groups. The next one is information on studies of the diagnosis. And
Very good.
Another one is, it isn't the end of the world. The kids will still play, laugh, and have joy.
So that is fantastic. So here's what I will say to you. We need to write this down. Years ago, there was, and it was like literally VHS tape, and it was called Breaking the News. And it was really all of that. So this was just a short clip that she focused on. I don't know what else she did, but I would say to you, if you are in a position of influence with clinical practitioners, these are really important things, because what they get in training is pretty nominal. Many years ago, and even currently when I talk to people, I ask them, what kind of training do you get? So if you are an audiologist, you clearly expect children who are going to be deaf, hard of hearing. It's part of what you do. Hopefully you don't see this as a catastrophic thing in the sense of gloom and doom for the child, but you understand for some families that may be terminology or diagnoses that are hard to first process and even later process. Certainly blindness or deaf blindness are words that we talked about yesterday that can be hard for families. So if you're in a position, even sitting down and having a conversation to try to influence, what I did with the doctor in Alaska is I said to him, Dr. Patterson, sometimes you kind of just go straight for the bad news. And this was after I had built a relationship and he figured out that I could really help him as opposed to be kind of one more person asking questions in the examination. And he said, I think it is my ethical duty to paint the picture of all the things that can happen. So he felt duty bound to paint the picture of here could be a potential side effect of a surgery. And, these families are just, their eyes are getting bigger and bigger and bigger. So he and I just kind of strategized. How do you give that information? So I will just say to you, it is important that we try to influence practitioners who may not have a lot of experience with this, what they can do. I think it's rare that an eye doctor such as Lori has this level of insight, that you might go into a private room, that you make sure people aren't interrupting, that you let people sit with their emotions, you revisit the diagnosis, you revisit questions. But I really love the added content of, first of all, just kids are beautiful, and that this kid is going to have good next steps. So to really package it within what they know about good next steps. They may not totally understand it, but just to say, hey, there's good intervention programs. I know kids who are doing really well with their sign language, et cetera, whatever it is. As long as we don't turn doctors into educators, I'm a happy camper, because we don't want them giving educational advice, because sometimes, as you might know, it's not appropriate. Okay, so I just wanted to start with that. So we're going to be talking about screening history, the ABCs, and then some formal diagnostic stuff. So what I would say to you is, again, you may get the kid from the clinical provider, and that's where you begin, or you may be the person that helps to identify warning signals, et cetera, to send the kid off to the clinical provider. In that case, hopefully you have some relationships established with the family. You can set them up for these evaluations, give them some expectations, maybe even attend. So here's a big, big, wonderful thing that we now have in our country, which is infant newborn hearing screening. So many years ago, we did not have this, and the mean identification of children who were deaf, hard of hearing could be 3 years, could be longer. And during that time, people often misunderstood what was happening with the child, and certainly were not paying attention to clinical needs such as amplification, and certainly not sign language or communication strategy. So right now, all 50 states and the District of Columbia have early hearing detection intervention programs and laws. Many major hospitals have infant newborn hearing screening, and we are seeing very, very different results. So right now, we know that about 2 out of 3 of every 1,000 infants in the US are born with a detectable hearing loss in one or both ears. And remember yesterday, we talked about the impact of unilateral hearing loss. We find with this particular process that babies are identified with both bilateral and unilateral hearing loss. They also can detect conductive hearing loss. So we have babies, believe it or not, who are born with ear infections. And then we certainly have babies who are born with sensory neural loss. So what's important is that you may have a family who learns very, very early that something's going on with the child's hearing. In my state, I think mean age of identification at this point is about 6 weeks. So you think about 6 weeks from a perspective of yesteryear, of about 3 years, that's really early. It also means it puts family in a situation, especially if they are not familiar with hearing loss, with some pretty big decisions early on. Now, just know that when we say screening, and I will be talking about screening for the duration of today, is screening is not evaluation. Screening does just one thing. It tells us whether or not we are concerned enough for additional information to be gathered. You either pass or you fail. If you pass, it means for what we are evaluating from a screening perspective in this particular screening protocol, we believe everything's good to go. But if there is some level of failure, the next step is further evaluation. So one thing just to be aware of with infant newborn hearing screening is that we have to ask families to come back for more diagnostics. And there's data from different hospitals, there's national data, there's probably state data with your programs to talk about how many families do come back for that diagnostics. So it's important that once a child fails a screening, we figure out what's that next step to get more information. So yes, and this is where I'm going to lose that big whole part that's right here. So now we're just going to talk about vision screening. So we do not have a parallel of vision screening with newborn hearing screening. We just don't have it. Not every baby leaves the hospital with a vision screening. The kids from a hospital perspective, from a birth, the baby is born in the hospital. The babies who are really evaluated for vision screening are the kids who are perceived as high risk. So they may be children in the NICU. They may be a child with an identified condition that the neonatologist, the pediatrician understands has an association with vision complications. But many, and probably the vast majority of babies leave the hospital after being born without any type of vision screening. So this is bad news, but it also is from a demographic perspective. The kids who would fail probably are a very low percentage. So we just learned about 2 to 3 in 1,000 have deafness. It's going to be even less than that from a visual impairment perspective. And so there hasn't been a national urgency for a parallel construction on the newborn vision screening. There is a tool, and some of you may have heard of this, the Neonatal Assessment Visual European Grid. People call it the NAVIG. It's a tool that was designed in Europe, and it is something that can give us an indication of whether or not a very young child, an infant, newborn, has the risk factors for cerebral or cortical or brain-based visual impairment. We have people who are trialing this across our country. We have people in my state who have really some of the leaders in this, doing the work through the Anchor Center for Blind Children, and they've trained several baby programs across the country. To go into the NICU, you need to have, permission from the medical community to go in, and they are finding children who are demonstrating brain-based visual impairment risk factors so that they can be identified incredibly early. So visual impairment screenings often rely on baby visits. So as moms and dads bring their babies in, we hope that the pediatricians are checking. If there's a concern, it is a mandate for Child Find to be doing vision screening. But what this means is that depending on your state and depending on the situation of the child and even the geography of the child, we may have children who do not have vision screening on a regular basis or a periodic basis to inform Part C services or even Part B services. So that's part of the reason that we're going to go over some of the components today, just to reinforce what you do. So when we talk about these components, we always say we really want you to know some of the clues. So you'll see I have slides that are kind of detective slides, people who are really looking for these clues throughout this presentation. So when we do this, we're going to be looking for red flags from family history, red flags for child history, red flags for appearance, behavior, and complaints. So these are things that you don't have to go to school to be trained in. I'm going to give you the overview today. Many of you probably do this. Some of it you will find is just intuitive. And some of it, I'm hoping by the end of the day, you will understand that you could just easily understand and implement in your everyday practices with kids. So this first part is, what are the high-risk family indicators? So depending on if you work for Part C, which is birth through 2, or you work for Part B, which is 3 to 21, we hope that there's some intake information from a family that can give us some clues as to whether or not we should worry about sensory disability if the child has not already been identified. So a question that should be on intake forms, or it could be a question that is just asked. We don't want everybody to ask the family, so hopefully there's some kind of organized system of how you collect this information, is there a family history of early onset hearing or visual loss? Does anybody in the family present as having a hearing difference, blind visual impairment, or deaf blindness? And that early onset is important because if somebody says, well, my grandmother was just diagnosed with macular degeneration, that's not a pediatric vision concern. It's concern for grandma, it's concern for kids as they get older. But from our perspective, we're really looking at early onset. The other thing is is there early onset visual problems? So not necessarily the impairments that we talked about yesterday, but does somebody in the family have a history, parents, of early onset eye crossing, color vision deficiency, needing prescription glasses? If you're talking to parents and they're wearing glasses, oftentimes this is a genetic predisposition for a refractive error. So it just gives us a clue, doesn't give us an absolute, but it gives us a clue that maybe this is something that we could think of for a child. The first one might be more tied to like genetic conditions. The second one certainly can be genetic in terms of the things up there, eye crossing, color vision, et cetera. But it's just to get a little bit of a wind direction on, do we have a concern? Family history for early onset conductive or sensory neural loss. So we're just probing those things in a very matter-of-fact, objective manner. Could be in a questionnaire, could be in an actual verbal conversation. And then this last one is really important. When we do our vision screenings, and most of us across the country follow this, but certainly we do in Colorado, is that if you ask a parent whether there are concerns about hearing or visual status, that by itself, even without supporting evidence of the concern, in my mind, is concern for referral to that clinical provider that would do that next step diagnostics. So if I have a mom say to me, something's just going on, doesn't appear to really hear me. There are times he listens and times he doesn't. I'm still going to do my work to try to quantify that. But in my mind, that is sufficient for investigation. If the mom says, there are times when I think that eye is crossing. Thank you for telling me that. I want somebody who really has the clinical expertise to do a checkup. So that in itself, on our vision screening and our hearing screening forms in Colorado, is grounds for referral, next step referral. So other questions for caregivers. Maybe the child already has been through a screening. Do they know about it? Was there an infant newborn hearing screening? Did the doctor do something? Just what were the results? And bigger than that, has the child ever seen an audiologist or had an eye exam? If so, what are the results? You would be surprised sometimes that parents may come back and they may say, the eye doctor noted that the eye was crossing, but let's just watch it. And I will tell you, we worry about those words. We don't like to watch things that can be interfering with all the visual skills that we talked about yesterday that could really interfere with development. So the goal is just to understand what was said and what were the results. This also may be a time that you unpack some misinformation. So you may have a mom that says, they suggested glasses, but we really haven't done it. That might be that follow-up to say, do you have that prescription, and really talk to them about, this kid is a -5. That really means you're nearsighted, and the kid would make more positive gains if he had glasses. So if this is not your comfort level, this may be where you pull in your sensory specialist working with the kid, either on an IFSP or an IEP. And then again, does the kid have a history of ear infections? In my state, when we recently revised, it was a few years back, our eligibility criteria for hearing impairment, including deafness, we actually have one of the things that people can check as criteria is a history of frequent ear infections. And I don't remember the quantification right now, but it's basically, has this kid had ear infections? I think it's something like maybe concurrently over a 3-month period. We worry about that. That doesn't automatically make you eligible, but it's the red flag that then we check for whether or not we're seeing a need for specially designed instruction. So bottom line is just start to get some information from parents. They may not provide it without the inquiry. They may not think that it's significant. So working on your teams just to say, how have we collected this information and can I have access to it? Or have we not collected this information? So here's some of our high-risk conditions. And we're going to talk about some of these in more detail, but most vision and hearing screenings will list these as risk factors. And these risk factors by themselves are grounds for referral for next step evaluation because they're loaded. They're loaded for the potential for a child to have a hearing problem or an impairment, a vision problem, or an impairment, or both. So we'll talk about these risk factors just to make sure that everybody's on board. You may be thinking something's missing. If it is, put it in the chat. Let's make sure that everybody has kind of an equal understanding of a risk factor. So this should say, if I would have had my thing on the right, this should talk about prenatal conditions. So these are things that we worry about prenatally when the baby is developing in utero. We worry about any kind of exposure to, oh my goodness, I said maternal infections, and that should be maternal. Sorry about that. So a maternal infection. So what that means is while the mother is pregnant with the baby, if she contracts a virus, that virus is transmitted to the child. There's no barrier between the mother and the developing fetus. And so if the mother contracts a maternal infection, the baby may experience it. And if so, it can cause birth challenges, birth defect challenges that affect vision and hearing. And the next slide will unpack that a little bit. Another question that I hope is in your intake And this can be a little bit of a kind of a touchy-feely, how do you get to this question, is was the baby exposed in utero to alcohol, legal or illegal drugs? So it's not always a really comfortable question. When I've talked to people who have done intake forms, they say they just put it very matter-of-factly. They just put it in there. We're not making any kind of judgment. We're just collecting information. And we're going to talk about this in a second in terms of the impact to the vision and hearing systems. Then also, is there a history of an in utero stroke or other complication affecting the development of the baby? So these are some of the things that can happen to a developing fetus that could result in deafblindness. Is there a concern with microcephaly? So bottom line is this is something that we can see. This is a baby who is born with an unusually small head, but let's just put it down to ask so that we collect that information. Are there midline organ complications, heart, kidney, liver? Sometimes we focus on the core of the body and the organs, but when you hear midline complications, oftentimes we can see visual problems. Sometimes we can see hearing problems. So it doesn't mean it's an absolute. It's usually something that may be associated, but you will see, for example, in many syndromes where we do have some of these midline organ complications, there's also vision and hearing concerns. I'm trying to admit somebody, yeah. Is there a history of genetic conditions that cause deaf, hard of hearing, blind, visually impaired, or deaf blindness? This is sometimes where educators know more to probe and think about this than some of the medical specialists. But bottom line is, do we hear a particular condition that we start to go ding, ding, ding? That's a condition that we would have worries about vision and hearing. These are all things that happen as the baby is developing in utero. So this is just an example of the form that we fill out as deafblind projects that give you some of the areas of complication we look at that I've just talked about. So these are the prenatal worries that we look at. So I'm sure you all have heard about the Storch prenatal infections, but I put this up just so that you can see the ones that truly have damage, potential damage to the visual and hearing systems. So we don't see syphilis like we did in the old days. At one time, that was much more of a concern. But with syphilis, there is still worries, especially if it's a vaginal birth, that we could see eye and ear challenges. Toxoplasmosis, couldn't fit that whole word in there. But again, toxoplasmosis, same worries. Rubella, CMV, and herpes. So I'll go back to rubella. It's been a success story in our country that when we developed an immunization for German measles and mothers were vaccinated ahead of pregnancy, that we don't see rubella like we used to. But in a few more slides, you'll see that we'd still see an incidence. So the worry for rubella is the unvaccinated mother, and that may include a mother who's a refugee or an immigrant where they're coming from a country that did not have the immunization. Or it could just be a circumstance for whatever reason that somebody wasn't vaccinated. But rubella is the exact syndrome that really launched our deafblind projects. Back in the 60s, we had an epidemic in this country, and we had thousands of children with rubella, and people really didn't know how to support these kids. They had congenital cataracts and some other visual concerns. They had sensory neural loss. They had some health complications. As a group, they were a high need population of kids, and we basically organized as a country. The U.S. Department of Education organized. This is when we first had our regional deafblind projects that later became our state deafblind projects. So even though we don't see this as much anymore, it's really because of children with rubella that we have a lot of our deafblind practices today. It was kind of a national response. CMV, cytomegalovirus, we talked about this yesterday. We worry very specifically about progressive hearing loss. It affects both vision and hearing, and same with herpes. So herpes would be sort of the same category as syphilis, where babies are more at risk for the vaginal birth if the mother is active with the syphilis and the herpes at that time. So you see other things in addition to vision and hearing that just gives you a perspective of the complications. Doesn't mean that all kids will have these particular considerations, but they are at risk. So Now we're going to talk about just prenatal exposure to toxins. So have you heard of that term, a teratogen? Do you know what that means? And then why do we worry about it? So if somebody in the chat just wants to say, why would we worry about prenatal exposure to toxins? What's the big deal? Anybody have had an experience with a child or just knowledge about why we worry about it? Do you worry?
Well, I can
Anybody?
say for myself, I don't know that. I haven't heard of that before. This is
Okay.
dumb.
Well, let's just go to the next slide. So teratogen is just a fancy word for saying they're agents that can induce or increase the incidence of birth defects in a developing child. So I've lost my little baby due to my design problems, but that's just a little baby that shows the effect of, you know, chemicals. And here's what's hard about teratogens is since sometimes they're legal. They could be alcohol. Alcohol is a legal drug, but if we have exposure, and I'll show you in the next couple slides, at a critical period of a developing fetus, the results can be very, very damaging. So it can be things like legal drugs, prescription. Many years ago, I had a colleague who worked with a young teen mom. When she became pregnant, she received prenatal care. Nobody really did a history to determine what she could or could not take from a medicine. And one of her regular routine medicines was an anti-acne medicine. And I don't remember the name of it, but it was a very strong medicine to control her acne. And this baby was born with profound vision and hearing loss complications. And in retrospect, the doctors wondered if that particular drug contributed. So she did not know. They did not ask. It was just one of those things that sadly happened without really doing good prenatal healthcare history to find out what she was taking on a regular basis. But we also know that there are illegal drugs, cocaine, meth, etc., that can create incredible complications with babies. So I have two charts. You can Google these pretty easily, but we use this especially in a class I teach when we're talking about fetal alcohol spectrum disorder. But I have two different ones and I show them for different reasons. But what's really powerful about this is that you start to see by week 4, the eye is really, really starting to develop. And so there's one more part of this slide that's really important, is that this is typically the time when women miss their period, where they start to find out they're pregnant. And why that's so important from an alcohol perspective is that oftentimes people don't know they're pregnant and they may be drinking. And one of the largest populations in the country that we worry about right now for babies who have fetal alcohol spectrum disorder are college-age students. Don't know they're pregnant, do not change their behavior, haven't started prenatal care, and there may be just recreational drinking. We also worry about alcoholism, something more serious than recreational drinking. So here we see the eye starting to develop about week 4 and week 5. Here it comes in the ear. So structurally, what starts to happen with the developing fetus from a sensory perspective to vision and hearing happens very early on. And then this continues. So you start to see with the eyes just where we do the primary growth, and then we continue to, let's just use the word cook, we continue to evolve with the visual system. Same with the ears, that there's a period of time that evolution really happens, time of the first prenatal visit. So by the time you go in, you can see where the eyes and the ears, as well as other aspects of development are that have already really started. This other chart, again, you can just Google these, gives you a little more information. So here we have the hot eyes. And again, this is that critical, highly sensitive period that's very early on into pregnancy, when you may know you're pregnant or you may not know you're pregnant. And then we have ears down here. So you start to get the sense of why that's so important. And what we know about a teratogen is that it can complicate the development of the eyes and the ears, as well as other parts. It also can trigger prematurity, which is going to be another thing that we talk about in a second. And that's important and showed beautifully here. because we see that the visual system continues to develop through that 40 weeks gestation. The ears kind of do some stopping, and one really fun little piece of data is that babies in utero have about 14 to 15 weeks of listening before they're born. They actually have the capacity to hear. They've done some pretty sweet little studies about mamas who are reading to their babies while they're pregnant, and then later when the baby is born, the mama reads that same book, and they literally have measured what's happening from a brain perspective, where kids are reacting to the words, the familiarity. So we have some pretty amazing data that tells us that hearing is functional in utero in the later weeks. Vision, not so much. Vision needs light, and it's a pretty dark environment. But bottom line is, this is why we worry about prenatal infections. This is why we worry about any kind of teratogen, that it really can damage that developing system. Hard sometimes to find this out, because one of the things I will say to you, and we spend a lot of time talking about this, is the last thing we want to do is point a finger. We don't want to cause guilt or anxiety that people did something wrong, even if technically they did something such as drinking beyond their control. The bottom line is, it's just good information. And if you don't have a lot of information about fetal alcohol spectrum disorder, I'd really encourage you to, and I'm helpful to send some resources, but it is a condition that requires some very specific strategies that have been found to be successful with the kids. So here's just some of the syndromes. So this is not all of them, but I've tried to give you sort of some highlights of what we worry about. So one thing I'd like you to do, if you would just humor me, and I think we have enough time, is pick a particular syndrome. So just, and you may have one based on a child that you know about, and I'll go back, but here's what I want you to do, is I want you to pick a condition, put the name of it in the chat, and then on your computer, just quickly Google it. So let's just say you're going to Google Down syndrome. What you can do is write hearing and vision concerns with Down syndrome. So just very quickly pick a syndrome and put it in the chat, which one you're going to do. And if some of you do the same one, that's okay. Google just hearing and vision concerns. And then we're just going to take about 3 minutes, put in the chat what you found out, and then we'll just do a quick talk about it. So is everybody ready to go? I'm going to give you about 3 minutes, and then Donna, just help me with the chat. People are picking something. Doesn't have to be a syndrome that I've listed. It could be another syndrome that you're wondering about with a child. And let's see what kinds of information we get.
And we already have some people picking some.
Yay.
So, yeah.
Okay.
I could read to you a few comments from earlier. I'm not sure, like, to go back. I feel like you went ahead, and some of the comments are coming in.
Okay, well, if there's something you think I should talk about, yeah, please do.
It's really just either answering your questions or comments based on going all the way back to talking about the doctor.
Okay.
Sometimes the professionals that are with us today experience as part of their job. They usually start with families, like they often go after the appointments, after that drop the bomb kind of happens. And then the person says, I go over the information with the family again, and then try to pick up pieces and show them that they are not alone, and that the situation may not be as dire as it was presented, and that they have multiple families that don't follow up after failing a newborn screening, and neither did the doctor, resulting in tons of misinformation before the official late diagnosis.
Yeah, that's right on. And I hate to say it, but I resonate with the drop the bomb, because sometimes that's how it really feels. And I will tell you, you can talk to a family of a 16-year-old, and if you bring them back to the day that they found out about the deaf blindness, it's just painful, a painful memory. I will say one of the things that we have with our deaf blind grant is we have a big ear model and we have an eye model. And when work specifically in Alaska, I traveled the bush with my eye model, and I would sit down and I would unpack the eye with the family. And sometimes I was the very first person that could truly explain what the eye condition was. The same that could happen with the ear, just what is this thing that has happened to the child? So really good observations. So has anybody found the vision and hearing concerns of some of the conditions? Do we see anything new in the chat?
So far, we see that they've picked a syndrome that they're looking up. So it's probably
Okay.
going to take them a minute to type it into the
We'll
chat.
give you another minute. So this is actually not a bad thing to do. So when you're trained in sensory disability, oftentimes people can name a condition or a syndrome, and the persons just start saying, oh, this is what we worry about. But I will say many of these syndromes or conditions, some of them have national organizations. So you can, like, for example, Down syndrome. I mean, there's certainly the, Down Syndrome Congress, Association, et cetera. And you can really go and spend a lot of time to learn about it. This is what parents do. And so sometimes it's good to do it yourself because there can also be misinformation. But I will say to you, usually you can get pretty quick information about whether or not there could be a potential vision or hearing problem or a disability.
All right, so we have some.
Yep, let's just try it. Let's do a few.
Stickler syndrome, cataracts, glaucoma, retinal detachment, hearing loss varies and usually affects the ability to hear high frequencies. Wolf
Excellent.
horn.
Yep.
Coloboma may be present for individuals. Possible low set malformed ears and hearing loss may be present. Bardet-Biedl. Hold on, it's moving. I see issues with vision loss, retinal detachment, but no hearing issues noted in search. And Goldenarr syndrome, characterized by abnormal development of the eye, ear, and spine. Pierre Robin, for congenital glaucoma, myopia with concerns of retinal detachment. Hearing, increased conductive loss. Trisomy 18 is another one. They
Yep.
include cataract and hypoplasia of optic nerves in both eyes. And juxtapapillary coloboma, retinal dysplasia, Bergmeister's papilla in the left eye, and hearing loss affects 50% of babies.
Yeah. So sometimes you may actually get some words and you may say, I have no clue what that is. So that requires more information. And this is where hopefully your audiologist, your TOD, your TBI, your O&M specialist are going to be some of your best friends. But it starts to give you an example. What you've also heard is that many of these conditions have other things. And as we talked about yesterday, sometimes when there's other things, the vision and hearing loss can actually take a back seat. And so really doing this work can give you more perspective. So we do this with the Deafblind Project all the time, and I will show you just a little bit more information. So those are all prenatal conditions. We'll come back to some of the etiologies in a second. So now what my blue thing that went missing said was perinatal. So perinatal is really right around the time of birth. So prenatal, you're not born yet. Perinatal, it's happening, you're born. And so these are some of the things that would be high-risk indicators for sensory loss that we worry about, is any kind of prematurity, whether or not the baby required oxygen. We've learned over time that it matters when you were born, but it really matters how much you weigh. So we worry the most about kids that are fewer than 1,500 grams, which is 3.3 pounds. I will tell you, sometimes and you've probably had this experience, you'll talk to a family and there are babies who are literally a pound. It's like they're a little baby stick of butter. We worry about those kids a lot. The APGAR score matters. Sometimes families may not remember, but you may have some information to talk about what the APGAR score was at a minute and then again at 5 minutes. And then we worry about whether we can see something at that point that might be a craniofacial abnormality. So it could be a cleft palate. There could be something about the face with the eyes. There could be something with the ears. So is there something around the face that starts to tell us that the baby did not have full, complete development? So that's, and you could actually put that at prenatal, but where we discovered, of course, is perinatal. So then we also worry whether or not the baby was hospitalized in the NICU for more than 5 days. And there's many reasons kids may be hospitalized. They may just be too early to breathe on their own, etc. But again, if they're in the NICU, that's a red flag. And then there's concern about hypobilirubin. And I spent some time looking that up yesterday just to make sure people understand it. But the bottom line is hyper always means too much. So these are kids who have too much of their bilirubin. I think I'm saying that wrong. But the problem is that if the child is premature and they need to have an exchange with this bilirubin, what can happen is that we can see complications. And so in red, it really talks about it can affect the brainstem, the auditory nuclei, and the cochlear nerve. So this is more of a worry for hearing loss than vision loss. But if this is part of that child's early history after birth, it's again a red flag. All these things are red flags. Doesn't mean the child will be deafblind, but it just tells us they're more at risk. And then the last, and we'll talk about this later again, is was there any exposure to ototoxic, that says mediations, that should say medications. So the bottom line is that we have medications that can keep kids alive, but they also are damaging to the hearing system. And that can happen right at birth, and that can actually happen later on, depending on the health condition of the child. So these are all kind of perinatal concerns. And here's just a little picture of born too soon. And what I will say to you is that this has really been a changing target in my lifetime. So I'm old enough that I actually remember when John F. Kennedy and Jacqueline Kennedy's baby was born and died. I was really a little kid, but I remember there was national sadness that their baby had died. And somewhere in my head, I just tucked that way that the president had a baby and the baby came too soon and the baby died. But it wasn't until years later that we actually had a training from Chris Roman and her husband. And Chris came to town and she was training Colorado about CVI, and her husband is a neonatologist. And he talked about, he said, do you remember that baby? And I probably was one of the few people in the audience old enough to remember it. Some people just know about it. And what we learned is that baby was born at 32 weeks gestation, which is shocking now that a baby at 32 weeks gestation was not viable to survive. Now we're seeing infants 28 weeks, 24 weeks, 22 weeks. It has really been a game changer. But what we know is with these little tiny people, just when I showed you that prenatal chart, how long it takes for lungs to develop, hearts to develop, eyes to develop, etc., coming too soon obviously brings incredible complication. And in the United States, we have the technology to keep babies alive, obviously from 32 weeks all the way down to in the 20s weeks. But what we don't have the capacity is to fix everything that doesn't ultimately develop, or that there's failure while the baby's in the NICU. So this little person was 1.2 pounds. So prematurity is always a red flag. So if you know from a history that a child was premature, we worry again about that birth weight. The visual challenges are many. So I'll just describe a few of them. We worry about a condition called retinopathy of prematurity. This is a retinal condition. There are different grades of ROP. There are different treatments, but at its worst, it results in retinal detachment. So it's a disease of the retinal from babies just here too soon. The retina does not have maturity. It's vulnerable to oxygen. It proliferates blood vessels. It can become heavy. It can tear away from the back of the eye. So we worry about ROP. We also worry about high levels of myopia, which is just another way of saying nearsightedness. So many times kids with prematurity end up with glasses, most often because of nearsightedness, sometimes because of farsightedness, but it can be extreme nearsightedness. We can see poor eye alignment, and we can also see brain-based visual impairment. So just by itself, prematurity is at risk for the child for a vision status. From a hearing impairment, we've already talked about some of the complications, but there can be severe complications. Sometimes there can be concomitant factors that influence the occurrence of hearing defect, meaning the baby had something already going on, which caused the prematurity. And so that hearing loss was well on its way and is just one of the symptoms kind of identified with prematurity. But in general, we just worry about it. There are also kids, and we all know them, that we say, oh my goodness, this kid went on to just really have a successful health body future, but we worry. So now we're talking about postnatal. And these are things that happen after birth. So typically kids are going home. This can happen across the lifespan, but here are things that we would worry about in early childhood, whether or not there's a postnatal infection. So we give the example of meningitis, encephalitis, group B strep, E. coli. So something that causes a fever. Yesterday, we targeted Helen Keller as having a high fever about 18 months. This is what we worry about, is that high fever that can really take out a visual system or a hearing system. Is there any kind of trauma? So shaken baby is a term that we still use. People also refer and have tried to rename this as abusive head trauma, but this can happen, especially in the very early years. We all know the crying baby can be a very complicated situation across families, and sometimes babies are roughly handled or actually abused, and we can have head trauma that results in brain-based visual impairment or hearing impairment. Does the child have a neurological disorder such as seizures or epilepsy or hydrocephalus? So we worry about anything that's happening with the brain. Bottom line is, remember yesterday we talked about the brain ultimately is how we see and how we hear. Did the child have an excessively high fever for a period of time? Does the child have cerebral palsy? So one of the conditions I didn't have you Google is cerebral palsy, but I will tell you, this is a population of kid that I spend a lot of time worrying about, because many times they clearly have varying degrees of bodies that work or don't work. And people can miss that they need glasses. People can miss that they have ear infections. People can miss there's brain-based visual impairment, or there's truly visual impairment. Because cerebral palsy has motor trackways that happen in the brain, we often see that if there's damage to those pathways, there's also damage to those pathways from a visual perspective, and that's where we see the brain-based visual impairment, and certainly at risk for hearing loss. So I always say when I meet a child with cerebral palsy, get ready, I start looking. If you read the literature, their incidence of refractive errors is off the chart. So many times these are kids who may not go on to have visual impairment, but they have visual problems. And if they're nonverbal, they may not be able to be clear about what they see and don't see. So we have to be good stewards of figuring out what behavioral indicators may be red flags. We may have to work carefully with clinicians to say, how do you evaluate this child who can't give you a verbal response, whether it's in a sound booth or whether it's in an eye exam? I would just say, go your extra mile. This is one of my worries, is because many of these kids end up with communication devices. And I have had this happen where I've gone into a school and I've seen these little bitty tiny communication symbols scattered across, an array. And I'm thinking, A, do you have the acuity? B, do you have the visual field? C, do you have the brain interpretation for all this stuff that's in such an overload perspective? So I have a very soft spot for these kids because I worry, and I have actually been instrumental in very late identification of vision concerns with kids who suffered for a really long time with people not understanding their visual capacity. So here's where we talk about those ototoxic drugs again, Samycin drugs, and we're worried about kids, maybe a kid who's had chemotherapy or another type of antibiotic. And you'll see a slide a little later that talks about just really understanding the medicine's effects on vision and hearing. So these again are some of the high risk conditions that when we hear, we absolutely need to gear up to make sure that proper vision and hearing screening and then follow-up has happened. So just again, some of the things that you might see in the deafblind census forms that talk about postnatal infections or postnatal things that can happen to kids that literally can change their vision and hearing. So here's just some background. So we talked about yesterday that we do this deafblind count across the country. On December 2021, there were more than 70 causes identified. So remember, we had about 11,000 kids. I actually think it was about 10,500. So of those kids, we had 70 causes identified. Some of the most prevalent conditions would be CHARGE, which is actually an acronym. Each one of those letters stands for something. Down syndrome, Usher syndrome, and then here we have CMV. Those were more of the high incidence cases with 100 or more cases. And then there were about 20 identified causes that had fewer than 10 reported. Some of these were like Hunter syndrome, Cogan syndrome, and some are very, very rare. So we might just have 1 or 2 cases reported annually. So lots of reasons that we know that kids very early on are diagnosed with deafblindness. Hereditary disorders, about 48% of the etiologies have an hereditary link. Stickler syndrome, Cornelia de Lange, increased but are rare. And then they talked about the prenatal complications accounted for about 14%, and then about 11% postnatal. Noted that rubella, as I talked about, is really not common. 30 kids had congenital rubella syndrome still, which is down from 83 in 2010. So the bottom line is we don't know the history of those kids, whether or not these are kids who come from other countries where mothers weren't immunized, or they're actually long-term US folks that they just weren't immunized. So while rubella has pretty much been extinguished, it's not totally gone. And what will make it come back again is lack of vaccination. And then we see etiologies that are undetermined. So we have almost 2,000 kids out of that census that people don't know why they're deafblind. There just isn't a reason. And this is important to understand because families sometimes are very troubled by this. They want to understand why did it happen. And sometimes we don't know, or it may be situationally, there hasn't been genetic care or next step medical intervention to really kind of tease out why that happened. Okay, so we're going to move into these ABCs. So before I do that, do we have any questions so far just about the things that we've covered about perinatal, prenatal, and postnatal? I'm assuming you've seen kids who fall under each of these categories. So any questions?
No questions yet, Tanny.
Okay. If you do, put them in. So now we have these classic things called ABC, and ABC stands for appearance, behaviors, and complaints. So these are things that may be inherent in your vision and hearing screening protocols, but again, they're things that you can do. I will tell you, I'm on a deafblind project in Colorado, and my colleague Gina goes out on a consultation, and it never fails. She is also our state consultant and something we call significant support needs. So that really is kids who have severe disabilities, multiple disabilities. So Gina will go out with her job specific to kids with severe disabilities, SSN needs, and work with a particular group of kids, and never fails. She comes back and she says, Tanny, I found a kid who's visually impaired, or I found another kid who's deafblind. And some of it is just this observation of what I'm going to talk about today. You may say, I know this, but I will tell you a lot of people don't know this. So this is good stuff to share with your colleagues. If they have a comment that says, well, you know, something doesn't look right, these are the things that we want to quantify because they can result in a next step referral to the clinician who can do the diagnosing. So appearance is pretty simple when it comes to vision and hearing. We're kind of just going to look at the kid's face. We're going to look at the kid's ears and eyes, kind of in context of their face. And the rule really is, it's this simple. If something doesn't look right, you need to check it out. We are a very visual society. We look at people's faces all the time. We notice things all the time. Gee, that person has red lipstick on. Boy, that person has straight teeth. Wow, that person has crooked teeth. We look at people's faces all the time, and our brain immediately starts giving us a story. So if you see something and you think, I'm not sure that looks right, that's a ground for referral. So we're going to talk about hearing loss first. So you may look and you may not see anything. There are kids that if I just showed you a picture, you wouldn't know if they were hearing or deaf. That's absolutely possible, and that's probably more the situation. But I will also say that sometimes there are telltale signs that give us that high-risk perspective. So kids with a cleft lip or a palate, remember we talked about some of those midline things we worry about, may be totally fine vision and hearing, but that's a risk factor. Malformation of head or neck, malformation of the ears, frequent earaches or ear infections, and this you may not be able to see in terms of something from the ear unless there's a discharge. But later we're going to talk about some of the behaviors that might suggest, yep, something might be going on with hearing. So here we just have some pictures where you can basically see what we might see with an ear that might give us a sense of maybe something's going on. So very clearly, if we see an absence of the pinna or the outer lobe, or we see ear tags, that's going to be more of a red flag than, that's just an interesting ear. And sometimes that interesting ear is actually the ear of the father, right? Have you ever had that discussion where people will say, boy, this kid has a really big forehead, and then you look up and you go, that dad has a really big forehead, and it's just the way they're made, doesn't necessarily mean anything. But this will give you a little bit of an information to say, let's keep looking to see whether or not we have concerns. So physical indicators of vision loss are usually a little more obvious. And in fact, this is the way a lot of kids are early diagnosed. And one in particular, one symptom in particular that I'm going to highlight. But I have some pictures here, but things that might be a drooping eyelid. So what we typically look for is what we call symmetry, that the eyes are in the same place, they're the same shape, they're the same size. We look to make sure just that external kind of big picture of the eye. But then when we look inside the eye, when we look very deliberately at the eye, if you notice something that looks incredibly red and it's not specific to an allergy, we worry about that. And absence of the pupil, which is our black center of our eye, absence of clear or full irises, which is the eye part of our eye that gives us the color, persistent tearing without crying. And here's the indicator that really tells us something is going on that probably is visual impairment, and that's nystagmus. So nystagmus is the back and forth movement of the eye. It's an involuntary, people describe it as a shaking or a wiggling. And nystagmus can be either sensory or motor. It always tells us that something is going on with the visual system. Sensory nystagmus is a symptom of an ocular problem, an ocular visual impairment. It has to be bilateral, it has to be early onset, and it has to be significant. But when we see nystagmus, we know two things. One is that the kid has some vision, and one is that the vision is compromised. So anytime you see that nystagmus, it is absolutely something for a referral. It tells a story that something is not right with the visual system. Because what nystagmus is the search for focus. So when I say kids have vision, it means there's enough vision that the child's brain is searching for focus. And that search is a little bit to no avail because there's something going on that they're never going to have complete visual acuity at a 20/20 level. So it's a search for focus. You also may see eyes that don't move together. Right eye doesn't match left eye. I always say when I do vision screening or vision training, where right eye goes, left eye goes. There should not be no lag behind. They should work together, but you can also see eyes that cross. They go up, they go down, they go in, they go out. That's not typical. And we'll talk about kind of the age that we worry about. It can be a fleeting thing or it can be a continuous thing, meaning sometimes the eye is crossed or always the eye is crossed. That is never okay. So these are pictures, if we saw one of these little people in our practice, we would probably immediately say, wow, something's going on. What we don't do is we don't diagnose. So I wouldn't say to a mother, your child has a ptosis. I would say there's a droopy eyelid. What I worry about with that eye is that the pupil is occluded, that eye is not a functional eye. So it depends on the degree of that lid. But we want to call attention to it and find out if somebody's looked at it. We have a little person in the top middle who clearly has something going on with a swollen eyelid, not okay. We have a child in the far right on the upper who has an opacity. We're not going to diagnose that, but clearly that's an eye that we're concerned about. We want somebody to evaluate. Lower left, an eye that's crossing. I'll give you a little hint. One of the things that we clearly see is that we see that these eyes are not aligned, but if you look at where the corneal reflection light is, you can see on the left eye, we got dead center pupil, and on the right eye, we have it on the out. So if these eyes were totally straight and I saw a difference of the location of these two refractions, that tells me there's poor eye alignment. So we actually practice this in vision screening. Here we have an incompletion of the iris in two situations. What we don't know is that whether or not this incompletion is just at the iris, which is the front of the eye, or if it travels back to the retina. The more it travels back into the back structure of the eye, the more compromised to vision. But again, we're not here to diagnose, we're not here to prognose, but what we want to do is get in so that we get some clear information. So ABCs, if you see something that doesn't look quote unquote typical, it should be grounds for further investigation. You can talk to your school nurse if you work in a school-based setting, but bottom line is talk with the family. Have they seen an eye doctor? Have they seen an audiologist? Have they talked to their pediatrician? What might be some next steps? So eye appearance also goes along with behavior. So you may now see, in addition to something not looking right, you may see some behaviors that give you these further red flags. So when we talk about behavior, we're not talking about bad behavior. We're just talking about what does the kid do that starts to give you a wonder of, wait a minute, that doesn't look quite right. So we'll just go through these. So some of the behavioral indicators of hearing loss, inattention. The child is just lost in space, not paying attention, maybe in his own world. This could be incredibly misunderstood, especially with a child who has additional challenges and people are just thinking, well, he's just not cognitively able to pay attention, when in fact that attention is really a lack of the capacity to hear and listen to what's happening in the environment. Lack of a startle. So you will see some of these things on listening or response types of checklists. But this is a kid that something happens that's loud and there's not a startle response. Atypical listening behaviors. This could be sometimes the kid is tuned in, sometimes the kid is not. Atypical vocal speech development. So we're not seeing what we consider good progression for understanding, how to do B's and T's and C's, etc. So other behaviors, and this might be, for example, pulls on ears or put hands over the ears. This could be an example of an ear infection. So remember, you may not be able to see it through the discharge of the ear, but you might have a child who's irritable. You might have a child who's pulling on the ears, breathes through mouth, cocks head to one side. And this is a very important indicator, balance problems. Not all kids with sensory neural loss have balance problems. But if you look at many of the syndromes, you will see, and I don't know if this is totally accurate, but I remember a training we had years ago, about 40% of the syndromes have an association with vestibular problems, so it's a concomitant condition. So you may see kids who really just have poor balance, and sometimes that can be your red flag to check out hearing. So here
Katie,
we have,
comments?
Yeah, please.
We have a participant that's talking about her son has had nystagmus since birth. It has affected him profoundly and he functions like a kid with high functioning CVI. He has no brain injury according to his MRI. The initial pediatric ophthalmologist told us that 8 months he would be fine, and just to make sure his teachers know that he isn't cheating on tests when he turns his head. Insert slap on my head emoji here.
Yeah, and I will say to you, so if your son, was it a son? I hope I'm not saying that wrong for some reason, has nystagmus, we're hoping that the eye doctor has looked in. If it's sensory nystagmus, it's due to something actually happening with the eye. There's also something called motor nystagmus that actually lives in the brain. It lives in the cerebellum, where the eyes are okay, but we have nystagmus due to something happened in the cerebellum. And these are kids who often have ataxia, so they have motor planning problems. But nystagmus, we always check out. And sometimes what we see in nystagmus is a head posturing. So kids will either turn their head, so I'm turning my chin to the left and my eyes to the right, and it's called a null point, N-U-L-L. And it's the point that kids know that when I do this particular head and eye posture, I actually see better, and we never mess with it. Just like if I leaned in to look for something, would you say, Tanny, I'm sorry, but you can't lean in? Nope, that's how I see better. If I put on my reading glasses. So I'm sorry if people are discounting that this is the way that he needs to see, but that might be a good in-service for his practitioners, just to say, this is what he does to see better. And if there is CVI, or brain-based visual impairment, that's like a different ball of wax. So thanks for sharing that. So here, and I'm looking at my time, as usual, I'm going to run out of time. So some of this I'm going to leave in your hands to read, but I've tried to give you some slides that just talk about some listening to behaviors that we worry about. I will tell you, I always worry about giving people months or, age ranges, but this is truly typical development. But I will say to you, what if we were talking about a 6-year-old? What we're not going to do is say he has the listening skills of a 3-month-old. Please don't do that. But please understand the developmental progression and why it's important. Now, this is for listening. We know that we will have some children who are deaf who will not follow listening skills, and they will do it another way. So we're going to talk about some of the tactile skills, but this just starts to give you some of the things that if a mom said, oh my gosh, there was a thunderstorm last night, he slept right through it. Or we went through, the Mall of the American and they had a band playing and he didn't pay attention. These are things that you may listen for that start to give you an idea. Could there be a hearing problem? But you see very, very early on, babies are in tune to the voices of their caregivers for soothing, for engagement, etc. And this starts to lead to language development. Follows 2-step verbal directions. This might be the child that only kind of gets 1, but doesn't get 2. So you have to tease some of this out from, is this a hearing difference or is this a cognitive challenge? Is this an experience challenge? So all these things are kind of that detective work. So here we have some of the milestones specific to speech and language development. So you start to hear that whole thing about vocal play, what's happening, making different sounds, repeating sounds, babbling in strings. So we start to get an idea of whether or not the hearing difference is influencing the child's capacity to understand and reproduce speech, hear and reproduce. So just really quickly, in the interest of time, are there other signs that you would worry about for early onset hearing loss that I didn't cover? We talked about some appearance, we talked about some behaviors. Anything else you want to put in the chat to share and educate our colleagues?
There is a question.
Yeah.
Is it common for a young child with hearing impairment, about 18 months to 2 years, to appear to have autism rather than hearing problems? Or can you see an obvious difference?
So here's what I will say, that first of all, that is a fabulous question. And this is why I'm a big believer in a transdisciplinary team approach, because if I wondered, I would want to bring my people trained in hearing and loss in people trained in autism. I will tell you that's been actually a topic of training in my state, that we are seeing more children with confirmed autism who have confirmed hearing loss. So it's not an either or, it's a both. And people have worked together. And so what we've done as a state is we've brought together our autism specialists and our deaf, hard of hearing specialists to work together to tease it out and figure it out. I think there's some research. I think there's some scholarly articles if you Google it, but it is an increased incidence of 2 conditions happening. So one, I don't think there's a concomitant feature, like if you have autism, you're more at risk for hearing loss. I don't know that. That could be true, but we are seeing more children with autism who do have hearing loss. So I don't know if I answered your question, but that's where it's like anytime there's 2 things that don't seem to go together, bring together the people who really know those 2 separate conditions. And how would you test that? How would you do a sound booth experience with a child. What can you do that's involuntary? What do you need to do that's voluntary? Because think about it. If the child has autism and is easily overwhelmed from a sensory perspective, we really want to understand what might be happening with the child not processing environmental sounds right, etc. So it's just it's a great question. I hope I gave you a little bit of an answer.
And yes, that was helpful. That is a great idea, bringing multiple professionals together. And there's one more question. At what age does a child with hearing impairment begin the random and frequent, like babbling or shrieking?
So people who are early intervention TODs or audiologists would probably like just give you a quick answer. But typically what we see is when people start worrying that babbling doesn't progress into like that repetitive sounds, that imitation of sound. So you may also, one of the things that I indicated that's in the literature right here is the voice may sound different. So you may get an approximation, but there's a vocal quality that tells you that there wasn't that full, rich completeness of the repetition. So here is just kind of traditional babbling development. So you could start to say, okay, are there a lot of different sounds? Or at 10 months, am I only hearing vowels? Am I only hearing consonants? What am I hearing? So I don't know if I'm answering it, but bottom line, this starts to give you kind of a trajectory of what you could expect. I will tell you, when in doubt, seek help. Just seek help, because we want to err on the side of the child. We don't want to alarm people. What I always tell families is that if we get information that shows baseline normal and people are like, gee, Tanny, you set me up to find baseline, something's not right, then I say, let's celebrate. We got baseline. We know where he's at. And if there's still a problem with babbling or speech or language development, it may not be hearing, it may be something else that we need to spend time looking at. Okay, I'm going to keep going, but Donna, thanks for reading the questions and thank you for putting them in. Again, my rule is if we don't get through my slides, we'll either figure it out tomorrow or I'm just going to say happy reading. So my goal is for you to get your questions answered. So we're going to move on to vision, and just know we got a lot more stuff on vision. Vision is a sense that impacts a lot of domains. With hearing, we say some impact. With gross motor, with that balance, if there's low or hypo or absent vestibular, and certainly communication, what you're going to see is a lot more impact with vision. And we start with this thing called eye contact. So we expect babies basically to regard faces, and I'll show you a little bit of research on this pretty early, but at 2 months, we kind of expect pretty consistent eye contact. By 3 to 6, we're asking babies to smile. I smile, you smile back to me, little baby. And by 10 months, we sort of see visual discernment that if I make a silly face, if I stick my tongue out, if I make my eyes big, if I frown, there's going to be a reaction. You don't have the pictures on these slides because remember yesterday I said if it's a personal picture, I don't put it in, and then I have to worry about copyright. So here's the power of the human face. So I will tell you the research on this is fun. Vision is the most studied of all senses. It actually was what I did my dissertation on when I developed a vision screening protocol for the play-based assessment that Tony Linder does. But if you read about what they do early on, it'll blow your mind. But here's what we know. Within hours, the newborn shows a preference for mom's face over a stranger's. Now think of that. That's not only vision, but there's some cognition going on, probably a little olfactory support too. By 6 to 8 weeks, eye contact with other people, we get into that smile we talked about. By 2 months, they make intense eye contact. By 4 months, they go, hey, who's that cute person in the mirror? So looking at the human face is something that we are biologically wired to do if we have the visual capacity. So this slide blows my mind. So again, you sort of see this whole thing, babies start to discern the happy face versus the non-happy friendly face. But 1 to 2 months, they're starting to go, whoa, you're not happy. What does that mean? 6 weeks, stable eye contact. But here's the one that I really want you to take away, especially with your kids who have additional challenges. If no enjoyable contact occurs, that should be eye contact. By the age of 8 weeks, the infant should be referred to an early intervention service and an ophthalmologist for assessment of vision for early intervention. That's the power of looking at faces, because it tells us that this kid has the visual capacity. Now, that doesn't mean early on, kids basically look at, your forehead to your hair. The more contrast you have between your skin and your hair, the better. But the bottom line is this is a high risk indicator. So when we were doing our vision screening protocol in Colorado, I was talking to our school nurse, and we were talking about kids who may have more aversive reactions to eye contact, kids with autism. And she said a really important thing to me. She said, I think you need to put it in the screening, Tanny, because even if it doesn't flag visual impairment, it may flag another condition. So again, not all reasons for kids with eye contact could be attributed to poor visual responsiveness, but a lot of it is. Culturally, we have some cultures who are not as eye contact, face happy as others. So you have to put all that kind of in a box and do that team approach of discussion. But bottom line is eye contact really matters early on as a visual indicator of risk. Now we kind of look at some of this capacity for near range vision. So does a baby watch their hands? And this is really important because by 3 to 6 months, and I'll show you a picture, if visual system is working, babies discover they have hands, which is very important because the eye leads the hand. And you'll see that basically the eye leads the body. By 6 months, we expect little people to see little tiny things like a piece of cereal. We don't necessarily ask them to reach for it. They may not even be eating cereal, but we're saying if you're sitting in your high chair and I drop something little and there's good contrast, are you looking down and do you have a sense of observation? Are you aware that something's there? So now we're kind of going into some distance vision. We expect by 3 to 6 months, if a person walks into a room from 6 feet away, that baby's going to look in that direction. May not be able to identify the person, but they see that blob of a person from that distance, able to focus on an object near and far, 18 to 24 months. And I'll show you in a couple slides just where we think acuity goes. So vision is near 20/20 between 36 and 60 months. So remember yesterday we showed pictures of blurred image versus clear image, but the typically developing kid is going to have this kind of progression. So newborn, you see, it's pretty rough. It's pretty much legal blindness from an acuity perspective at newborn. Then we start moving in. So by 6 months, look at what happens, even from 3 to 6 months. So vision is late to develop. It's one of the last developments out of the chute from a newborn perspective. When we talked about what happens in utero with hearing, vision really starts when you're born and when your eyeball is really totally evolved. But we go fast, and that's why this first year is so important. That's why early identification is so important, is that the kid is really wiring for vision. You're literally doing neurological wiring for vision. So here's just some examples. We talked about those little Cheerios, 6 to 7 months. You notice if I'm going to do this, I got some contrast between the Cheerios. If mama doesn't want baby to have Cheerios in the mouth, I'm going to have to be pretty darn quick that this is a visual task and not a reaching task. But it doesn't have to be a Cheerio. It just has to be something little. You can do a cake decorating pellet, whatever it takes. Babies sometimes spontaneously do this where they reach for something really tiny and you go, there it is. So this one may freak you out. I got these eyes moving, but just know that there are muscles that control our eyes. There's 6 muscles. So we talked about that eye crossing behavior. Sometimes that is poor muscle imbalance due to a muscular situation. But we are always looking, again, right eye goes where left eye goes, and they can do full movement up to down, up all the way to the top, to the bottom, left to right. So ocular motor skills. So we want to spend time looking to see whether or not babies are really moving their eyes together and they're developing skills that require kind of that coordinated movement. So in the very early months, we do not see independent eye movement from head movement. So actually, if you turn a newborn's head to the right, the eyes will go to the left, meaning the eyes are not independent of the head. They work together. Sort of where the head goes, the eyes are doing some kind of counter reaction. Then we start to see the eyes separating and saying, hey, man, I want to have some independence. And they break through and they can go in all directions, but they should move together. So this is just something for you to have in your records about when we expect babies to fix on something. So when I talk about fixation, it's a lock on. Kids lock on to the thing that they're looking at. It could be my face, could be my hand, could be my thing in my hand. Once you lock on, then the next step is to see, can you stay with it as that object moves? So you'll just get a sense here about what we look at in terms of tracking. Starts vertically, then goes horizontal, and then we start seeing horizontal across midline, that the kids literally can cross midline. And what we're looking for is that the eyes are aligned, the movements are smooth. And this is a very important thing because it tells us that the eyes are coordinating and they're developing the capacity to travel together and to follow a moving objects. So tracking always means you're following something that's moving. So you look at 11 to 12 months, they can watch something that's moving fairly fast. Here we have a little bit of depth perception. So the idea is that both eyes are not only working together from a motor perspective, but they're actually the capacity to see one image. We call this fusion or binocularity, where the right eye image and the left eye image converges into the image. And how we see this with depth perception. So if that baby is allowed to pick up that Cheerio, do we see accurate reach or not accurate reach? So that's a red flag. If we see a child who really has an inaccurate reach or is missing steps, there's a little bit of a surface change, then we worry about those eyes working together. In the interest of time, I do want to show you this. Many vision screenings are not going to talk about field, but I will tell you, really, this is something I'm hoping that you and your colleagues are paying attention. This is a video that one of my friends did of a little person, and I have permission to show it. But let me just put it on and watch, because you're going to see field loss. Just take your little hand away so she's more observant. There it is. Little panting that says I think some of it cut out. I think you couldn't see where my friend went on the video. So let's play it again, and I will just say, so when it's straight over, she sees it, she's moving over to the left, baby can see it, and then we re-engage where it is. So this is a little person that had a field loss more to the left, to right than her left. The bottom line is that's how we check field loss. We get that fixed, we keep the head still, and we start to do some movement, and we're looking to see where that little person may be missing following. And that's really important because especially kids with brain-based visual impairment, we see a lot of field loss. Sometimes we see lower field loss. And where do we put things for kids to look at? They're sitting on their high chair, things are lower. This has also travel implications, but it doesn't have to be lower. Just like we showed you those pictures yesterday, field loss can be all over the place, but pay attention. But remember, head needs to be still, because if I start moving my head, then you don't know it's a field loss. You just see that compensation. And here's my picture I wanted you to see. This is a kid's hand. So what I love about this is you see this little person, this furrowed brow, something's above the kid, and here comes the hand. So remember that vision really leads the hand if you have vision to lead the hand. If a baby is blind, then we're going to be doing different things to really work on reaching. But bottom line, 3 to 4 months, hand watching is evident. And by 4 to 6 months, we're looking at a pretty coordinated visual reach. So here's just, again, got 15 minutes. I'm looking at some of the things that we want to see is Are they reaching out at this point at 3 to 6 months? They may be just batting at something. They're just making gross attempts. But yet, as you'll see, as we get by 6 months, we're kind of looking for some accuracy. So the kid who overreaches or underreach, we're worried about this. The kid who looks away while reaching, we're worried about this. So this starts to give you some of those visual milestones. When you see try to move toward an object that's at least 5 feet away, again, this is vision leading that motor quest. So if we have a kid who's parked, part of the thing is like, how can I move that object of interest not 5 feet away? Do I move it literally within hand's reach and I get that hand coming up? But what's my sense of that child's capacity to use vision from a motor perspective? Pick up Cheerio, Lint, and this just goes down to start to give it. So one of the things in rats, my little blue bar is gone, but you should have this in your handout, is that what that blue bar said, I think, or what it was supposed to say, is that not only are we looking at these milestones, but we're looking at how they're executed. So now I'm going to tell you what I call the compensatory behaviors of vision that tell us something's going on. So this may be a kid who still fixes, still follows, still does some of those things, but how he does it is of concern. So this is when you go, yeah, you looked, but because you did this, now I'm worried. So this is the kid who closes an eye when looking at something, or covers an eye, or frowns, or squints, or tilts, or turns ahead. When we see any of these behaviors, it tells us that the kid has something going on and they're compensating. So if I frown or I squint, I'm actually putting pressure on the lens of my eye to try to increase focus. But I do it because I don't have normal vision. That's probably a kid with a refractive error. If I cover an eye, that tells you, hey, one eye is working better than the other. And I'm just kind of saying, this eye is getting in my way, so I'm just going to get it out of here so I can do the rest of my work with the eye that seems to be the most functional. Not a good thing. Same with head tilts, etc. This could tell us about a field loss. This could tell us about something else going on. This little guy could also have torticollis and has nothing to do with his vision. But the bottom line is any kind of head or eye posture is not typical. The kid's doing what he needs to do, has figured something out, but we want to investigate it because it could be that this is a child who benefits from glasses. Could be that this kid has amblyopia, and we need to see a doctor to see if there's a next step with patching. So here again, we have closed eyes or face turn away when listening. So there are kids, we may think about this, especially with brain-based visual impairment. It's too much for me to look and listen at the same time. So I'm going to close my eyes and I'm just going to pay attention with my ears. Conversely, what happens if a kid averts gaze, seems to be looking at the other side? So just like we were kind of appraising that face, we're going to appraise how are you looking and is it telling me something? So here we just have a picture of some of the things that we worry about. Tilted head, screening, closing one eye, an eye turning in. Does the kid get really close to something or bring things really close? Now, if I'm really looking at visual detail, I might get a little close, but this is the kid who kind of does it all the time. And what you're sort of learning is this is where the kid sees best. But this is not typical. So I'm moving my hands to be like about 3 to 5 inches from my face. If I know that's where the kid sees well, that's good intervention, but that tells me something's going on, that the kid is not distancing out at an age-appropriate level. We'll come back to that slide tomorrow. Do we see kids overly interested in lights? Is it like lights win no matter what? So there are kids who truly have some organic eye disease where they're just fascinated with lights all the time. Does a kid have a certain color that's a strong preference? So this is not like, hey, little girl, what's your favorite color? And she says brown or pink. This is the kid that seems to look at things more because they are a specific color. And we know this is associated with brain-based visual impairment with some kids. Seems to have inconsistent abilities. And so this could be the mom who says, you know, he just looks better in the morning, or he does better, you know, in the afternoon after his nap. What we know, especially with brain-based visual impairment, that there can be a fatigue factor. That's true with ocular, But what we know is sometimes it's not about the time of day, but it's actually about how we've set up the visual environment and whether or not it's easier to navigate than others. But that's a red flag. Does the child look away when reaching? So we see the kid on the bottom left, she's clearly eyes are focused one way and she's reaching out. We see this with brain-based visual impairment, and there's different theories. Some of it is that if you do not want your hand and the movement of your hand polluting your visual display of the object, you look, you target the object, and then you just do that movement because you know where it is and you can get it, and you don't have the interference of that moving visual target toward the static visual target. But that's something we worry about. And then we've talked about over and under reaching. These are also red flags. This might be a little harder to tease out. Oops, so maybe not this one. Appears only to see an object when it's separated or isolated. That's pretty easy. So you have a picture of a little person with a black high chair and there's just a red spoon on it. That's probably a family that's learned if you put a lot of stuff on that high chair, he's not going to find his red spoon. So we give him one thing. We see a little guy in a room that is just loaded with stuff and he's retreated to a corner. It's too much. So we have to really take care that we're not, that there are kids who can see through the clutter and kids who can't. Do you have kids who stumble over objects in paths? Again, that can be an indication of a lower field problem. Or you bump it into the wall. That could be a problem with visual field to your side, a temporal visual problem. Do you have kids who are really hesitating? So I have a picture of here's some tile and here's a wood floor. And you have kids who are literally stopping because they don't know if that's a step down or if that's just a surface change. So they may get down on their hands and feel it. You may have a kid who really hesitates, or you can have a kid that is a step and they miss it. So again, those are some depth perception problems. And that could be that both eyes aren't working together, or you could have an acuity problem that's different. Right eye has more vision than left eye. You have kids that just avoid doing visual activities or lose interest early. So lots of these things you can read. So I got 10 minutes. So what we talk about with complaints is that complaints in vision screening programs for older kids, will talk about kids who talk about headaches or they're sick to their stomach. They have their ears hurt. They actually are complaining. What we know with little people, and especially little people who are nonverbal, either because they're young or they have additional disabilities, they may not complain, but this is where we have to kind of pay attention. So the things that I put in here is, do you have that tugging of ears? Does a kid do something, they whine, they do something, and you get a sense that something's happening with their ears? Are they overly sensitive to bright light? So they're squinting when you go outside, even when you're thinking, wow, it's not that bright out. Do they seem to have burning or itchy eyes? Do they rub their eyes? Do they blink? So bottom line is sometimes you have to tease out what's a cold, what's I'm tired. But just, is there something that really gives you an indication that the eyes are bothering them? And then this last picture, we have this kid who just looks totally overloaded, holding his head. This could be a kid who has a headache and doesn't have the skills to say my head hurts. You just have to be really a good observer of that behavior. Rubs ears, rubs eyes. We've talked about this. So bottom line is, if you see these things, whether they're through a vision screening or hearing screening or parent interview, or you're just observing a kid like my friend Gina who goes into the classroom, it's a good idea to talk to people to say, what do we think about this? Is this grounds for a next step? What data have we collected to say, maybe we really need one of these clinical professionals we talked about earlier in the PowerPoint to do some diagnostic. If there's a school audiologist, that might be really easy. It's harder with eye exams because the only person that can really do an eye exam will be a medical specialist. That's where we get into issues about who's going to pay for it. Is it provided through the family's insurance? Is there a free well baby? How do we do it? But that's really up to us to figure out how can we get the information? Because again, yesterday we talked about early identification. One of our reasons is mitigation of medical concerns. This might be a kid that we put glasses on and all those things go away. This might be a kid that gets tubes for his ears and it goes away. It also could be a kid who's amplified and we start seeing, more attention. Or we may have situations where we now know what can't we do from a clinical perspective. Now, what's our next step? So I would just remind you that one of the risks of deaf blindness is I have two puzzle pieces, one saying hearing loss, one saying vision loss. We can do everything right with audiology and people aren't saying, hey, have we checked vision? We could do everything right with an eye exam and we're not saying, hey, who's checking hearing? So this is where we have to be good stewards of both. But I would say to you, if you have a kid and you do know there's hearing differences, please check vision. If you have kids that you know there's visual differences, please check hearing. You may be the person on the IFSP team or the IEP team who asked that question. So remember yesterday when we did our definition, we asked, does the learner have enough vision to compensate for his lack of hearing? Does the learner have enough hearing to compensate for his lack of vision? If the answer is no to either to both questions, the learner usually can be defined as deafblind. And that's where tomorrow we're going to be talking about deafblind strategies. And we'll be talking about things you can do to enhance from a hearing perspective, enhance from a visual perspective, but then all the things that we do that when you combine that interactive loss, you're putting together that may be tactile. So once we're diagnosed, we'll find out whether or not we need those things called amplification, glasses, etc. We hope there's prompt referral, and thanks for saying that with our eye care specialist that we showed the video of. Absolutely, we're hoping kids are next step referred to personnel who are trained. Family support should be identified, what's really helpful and needed for the family. And then we're going to really begin our assessments to kind of figure out what are the strengths of this kids, what are the needs, and what are the priorities, both of the child and the family. And that's where we can really start the intervention and instruction. So tomorrow we're going to be talking about some more big topics. We're going to talk about something I call sensory packaging. How do we know what the kid hears and sees, and how do we put it together for maximum benefit? And then we're going to talk about the strategy of sensory preferences, pacing, hand under hand. If we have time, we have some problem-solving vignettes. And then if it's important to you, and I'll take stock in the morning or in early on when we meet, is let's just talk about some of your kids, not from a personally identifiable information, but just where's it at that you might want some help with some strategies. So I apologize that my video or my PowerPoint wasn't as pretty as I made it. I don't know what happened that it switched design. But with that said, what did I miss and where are your questions? According to my time, we have 6 precious minutes.
Penny, there's a comment.
Yeah.
I hope our state early intervention agencies are getting this information so they are looking for these specific things so we get these referrals early.
Yeah, and I see, Donna, you put in informal functional hearing eval. Absolutely. So, we've been talking about screening today, but then there's going to be more formal tools that we're going to use to really quantify what we know. That'll be a little bit about tomorrow. Absolutely. Okay, anything else? I'm kind of scanning. I'm in the chat now, but is there anything in particular that either I didn't mention or you think or I said it wrong? I mean, quite honestly, correct me if I did something that you think I need to be corrected on. Nope, we're good to go. So here's what I will say to you. It is stunning to me when I get phone calls. I worked for the Department of Education a long time, and it happens about once a year that we identify a child late. And honestly, there are days I put my head on my desk because I keep thinking in this day of age, we have so many resources. We have opportunities to really identify kids. And so that hurts my heart, but I also will tell you that there was a time in my practice that I worked with a little guy. I worked in Alaska. This little boy was adopted. He was very, very premature. He was a little guy who was exposed to alcohol in utero quite significantly. When he was born, the delivery room literally reeked of alcohol. He was adopted. I went to the home. He was the littlest baby I had ever touched at that time. The foster mom just put him in my arms because she got a phone call, and I'm holding this little guy going, oh my Lord, this is the tiniest little person. And he was a kid that taught me a couple things. One was he was significantly nearsighted in one eye. And when we went to the eye doctor, my friend Dr. Patterson said, I'd give you glasses, but this little tiny face, I'd have this really big collection and correction on one eye and nothing in the other eye, because the other eye was not a viable eye. And so the mother said, and he was about, I think he was about 15 months at that time. She said, what about contact lenses? And this was decades ago, a while ago. And the foster mom convinced the eye doctor to give a soft lens. So first lesson was we got the soft lens. So he was a -20. So if anybody knows what that means, it means you are really, 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 really nearsighted. I mean, pathologically nearsighted. And so about a month later, I met the mom back at the doctor's office. She said, Tanny, you want to see how the contact lens goes in? She put this little guy down. She said his name. She said, I'm going to put in your contact. And I watched this baby open his eye as wide as he could so this lens could go in. And here's the amazing news. Within 1 month of him wearing his lens, the PT said, I can think of no other intervention that's happened to this kid that had advanced his motor development other than he can see better. Absolute truth. That's lesson 1. Lesson 2, I gave my heart and soul to this family. And at 3, they went on to the school district. And when he was about 5 years old, his mom called me up and she said, Tanny, I need to tell you something. I said, what? She said, name of the baby has a hearing loss. And I said, how long did he have something that just caused it? They're like, no, they think he's always had it. And I will tell you, I still grieve the fact that on my watch, I missed it. So I will say to you, we absolutely have to say vision loss, check hearing, hearing loss, check vision. So with that, I think we're probably ready for the ACVREP code.
Thank you, Tanny. And I'm going to give the code, and then there is one question.
Oh, okay.
Okay, the ACVREP code, and you're going to email this to Becky. If you need her email again, maybe Becky will put it in the chat. The code is 06062002. Again, 06062002. And Becky put her email in the chat. All right, last question. Can you touch on how our optometrists or ophthalmologists diagnose blind and visual impairment?
So here's what I would hope, Diane. I know Diane, so I'm happy she's here. The bottom line is what we hope is that when they do the full dilation and they really can look at the internal ocular structures, et cetera, if it's ocular visual impairment, those things should be obvious. So we know, for example, if there's a coloboma, we know if there's nystagmus, we know if there's retinopathy, prematurity, we know if there's optic nerve hypoplasia. So there are things that should be visible under the examination that tells whether or not something's happening. The eye doctors also can do I don't want to say involuntary, but basically based on how they use their equipment of the dilation, and then they have lenses and lights, they can figure out whether or not a child is nearsighted or farsighted.
There's a correction. It typed in BVI, but she actually wanted to know about CVI. So how
CVI.
Diagnose CVI? Yeah, she made a correction in that. So
I'm going to do this really fast, and if you need to go, I would think Donna will agree you are technically excused since it's 3 o'clock. So here's what I will say to you. That's a great question. So just know there are good ways that pediatric ophthalmologists and even optometrists, and I don't mean to say even, but and optometrists can diagnose ocular visual impairment. What we hope is that at this point, it's in the literature. So we have some people who have been pounding the pavement in Europe, people who've been pounding the pavement in the United States, who are ophthalmologists to make sure that people are understanding brain-based visual impairment. The NAVIG, which I talked about, which is the tool that people are using in some NICUs is really groundbreaking because it's giving ophthalmologists more insight about what are the risk factors, as well as neonatologists and pediatricians. What we hope with our ophthalmologists is that even if they do not see something going on with the ocular structure, that due to a history of neurological compromise and significant visual behaviors, they're starting to put it together. Does that mean every ophthalmologist understands brain-based visual impairment? Absolutely not. So it's kind of like safety in numbers, that once you get one, you start bringing kids into that one. So we've seen that in my state. We've had people at Children's Hospital who are really, really cognizant of it, and they've trained their colleagues. We've had TVIs do grand rounds. We just had a national conference where we had some pretty wowzer-dowser people come in and train some of our local folks. How I did it in Alaska years ago, Jim Jan was a personal friend of mine up in Vancouver, who was like the grandfather of cortical visual impairment, really in North America. And I literally brought in ophthalmologists to listen to him. Some of them thought he was nuts, and some of them leaned in. So I will say there's some really good medical research in their literature. So we have CVI in the literature of special education, specifically blindness, certainly occupational therapy. But I would say if we get your hands on things that Gordon Dutton has done, he's one of the most great guys. Meredith Lofty is another one. He's working for Perkins School for the Blind. It's getting into their literature. It's getting into their journals. An APOS, I'm trying to think if that's the Association of Ophthalmologists. I can't remember if it's association, but it's APOS. I think it's APOS. But bottom line is Linda Lawrence out of Kansas. If we give them literature that's written by their colleagues, sometimes I think we have more of a dent opportunity than if we give them our literature and education. I will tell you at the conference that I was just at, and I'm mulling it over in my head because it blows my mind, is they are giving statistics right now that 1 out of every 30 children has cerebral/cortical visual impairment. So they are including populations of kids with ADD, populations of kids with ASD, populations of kids with Down syndrome. Now, not all these kids have the classic cortical visual impairment that many of us have been trained on in this country, but they have other visual phenomena with their dorsal and ventral streams. So I will say to you, it's blowing up. It's blowing up faster than I think eye care specialists are keeping up with, and even special education trained personnel. So I don't know if I'm answering your question, but what I will say is that I think it's our job to help them. And the best way I know how is to get to their medical literature in front of them and start some conversations, to go to those eye exams and start those conversations, to find the doctor who gets it and literally use that person to speak to other doctors in your community. So Diana, I think you probably know all those things, and you probably even have some other ideas, but I will say this data that's coming out with 1 in 30 is blowing my mind because it has huge ramifications, not just for deaf blindness, just for special education as it is, and what will be accommodations versus what will be specially designed instruction. So I don't know if I did any justice to it, but tomorrow I will say if people have other ideas, let's start the day tomorrow just saying, what did I miss as a recommendation? Because it's huge. Diagnosis means intervention and understanding. So we want to get it right. So with that said, I stole 5 minutes from many of you. I hope you have a good rest of your night.
Thank you so much, Tanny. That was terrific.